Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. That is on a very important topic, that is closed loop anesthesia delivery system. Is the future autonomous? So we need for this topic we need someone who is expert. So I would like to invite eminent speaker for this webinar. He is none other than Professor Dr. Nishant Kumar sir. And let me share some of the achievement of sir. Sir has done MBBS, DA, DNB, MNAMS and Professor Department of Anesthesiology at Lady Harding Medical College and Associated Hospital. So without any further delay, I would like to invite sir and hand over this session to sir. Sir, over to you, sir. You can proceed from here.
Thank you, Faraz, and a very good evening to all the viewers and listeners. So, today we'll be talking about closed loop anesthesia delivery systems. So, is the future autonomous? To start with it, I don't have any disclosures. I do use the names of certain brands, certain companies, but I do not endorse any company or product. There are absolutely no conflict of interests whatsoever. So, the objectives of today's talk would be: what are the different types of anesthesia administration? What is closed loop anesthesia? What are its advantages? How can we administer closed loop anesthesia? What are its disadvantages? And what does the future hold? And what are the future research possibilities that this technique offers? So, we all know that the anesthesia delivery systems can broadly be classified as open loop, in which there is a manual control. Everything is controlled by the anesthesiologist. There is no feedback. So, the best example would be your open drop ether method, wherein you're just observing the this thing. What you're saying is the clinical features of the patient's respiration, color, and everything is controlled by the anesthesiologist with no input from the electronic device or how the anesthesia is being administered to the patient. Then we have the semi-closed loop, in which some human intervention with feedback, like the common modes, the workstation that we use, or the ventilator that we use. We have an SIMV in which there is some amount of human intervention with feedback. That means that the machine recognizes the patient's feedback and modifies on its own as per the limit set by the anesthesiologist. Now, what is closed loop? Closed loop is a completely automated adjustment using feedback from the patient. That means that the anesthesiologist just sets certain targets for the machine or the limits, and then based on the patient feedback, the anesthesia system, the gas delivery, the agents, whichever is to be delivered, is administered by the machine itself. So it is completely autonomous, so to say. Now, to have an ideal closed loop system is almost next to impossible. There is some amount of human intervention is still required, but we are moving closer to the closed loop automated adjustment systems, as we'll see in the following slides. So, to define a closed loop anesthesia delivery system, it is an automated system using real time feedback to adjust the output, and it adjusts the drug delivery based on patient parameters. So basically what it does is, as you can see in this cartoon, the main aim is to get a maintain a depth of anesthesia. So we have the monitors which is connected to this patient. So the feedback is, in this case, is BIS, which goes to the computer or the algorithm on which we have a TCI syringe pump or the inhalation agents, and the dose of these drugs is based to target a particular BIS. This is a very simple example of how a closed loop anesthesia delivery system works. Suppose we want to automate the delivery of propofol or say the inhalation agent. So the main aim is to maintain a particular BIS or a particular MAC. So we set the feedback as a target BIS or a target MAC, which is being fed by the patient to the monitor. The monitor translates it into an algorithm, and on the basis of algorithm, the output of the drug is adjusted by the machine itself. You're not adjusting the drug. Like, the main difference between the manuals, the semi-closed and the closed loop anesthesia delivery system is that you observe the BIS. Okay, the BIS is 60. That means that the patient is getting light. So you increase the dial setting so that more anesthetic agent is delivered. Or if the BIS goes below 40, you come down on the anesthetic agent so that the depth is the patient becomes a bit lighter, right? In this case, everything is being done by the machine itself based on the feedback obtained from the patient. So, to classify it further, the closed loop anesthesia is ventilation control, hypnosis control, nociception control, neuromuscular control. Now, these are the four things that we have been able to achieve, but that is not anesthesia only, right? So, with these closed loop systems that we have at present today, we have been able to achieve the ventilation control, we have been able to achieve the hypnosis control, to a certain extent, the nociception control and the neuromuscular control, as we'll see in the following slides. What we still need to work on is the hemodynamic control. That means if the BP goes up and down, then it should be able to modify the drug dosages or start or prompt the anesthesiologist to load up new drugs, or if the drugs are preloaded, to start their infusion as and when required. Temperature control, to start, heat or cool the patient as and when required, and the metabolic control. Now, this will be the most toughest of the job. So, these three are the future uh, advances that we can think of when we talk of closed loop anesthesia. So, now if you see this, basically what it means is that we have a monitor which gives a feedback to the controller, which adjusts the drug dose, which is ultimately delivered to the patient. So, the components of a closed loop anesthesia delivery system would be monitors, which will provide the patient feedback to the machine. And these monitors, which we commonly use in the closed loop anesthesia delivery systems, include MAC, that is minimum alveolar concentration, BES or entropy, or any of the processed EEG as a surrogate of depth of anesthesia. Maybe the noxious stimuli using Conox system or any other noxious stimuli processed EEG. Train of 4 for regulation of muscle relaxants. So these are the monitors which will decide the core anesthesia drugs to be administered by a controller. Now, this information is fed to the controller, which has pre-fed algorithms on which the final output of the drug is based, which is carried out by actuation subsystem, which could be a vaporizer when inhalational anesthesia is used, or target control infusion pumps when TIVA TCI is used, right? So these are the three basic components. So how does it work? The sensor provides the feedback, which is either a MAC or the process EEG signal. Controller compares the real-time data with the target value. That means it will decide whether the target range of MAC value, MAC or process EEG is low or high. If it is low, what it will does is it will reduce the vaporizer or the infusion pump output so as to bring the MAC or the EEG up. And in case the real-time data is high, like in high BIS, that means that the patient is light, and the controller will instruct the actuator or the vaporizer or the infusion pump to increase the output to further deepen the plane of anesthesia. So this is a very simplified mechanism, how a closed loop mechanism works, with no human involvement at all in the maintenance phase. Obviously, yes, in the initial phase, the commands, the targets, the limits are to be set by the anesthesiologist. So, as we all know, we provide anesthesia using inhalational agents and the total intravenous anesthesia, and automated systems have been developed for both. It is not only for total intravenous anesthesia and TCI, target control infusion anesthesia, it is for inhalational anesthesia also. As of now, I know of these three workstations. As I said, I would be using some company names. I've got absolutely no conflict of interest with any of these. We have the Draeger, we have the Getting iFlow, and we have the Mindray A9, which have the automatic control of inhalational anesthesia. In Draeger ZS model, it is called the total control anesthesia. In Getting iFlow, it is called as automatic gas control. In Mindray A9, it is called as automatic control anesthesia, or the ACA. Apart from this, the Draeger ZS also offers, apart from the control of the anesthetic component, Draeger ZS also offers a smart ventilation control. That means it takes over the um, hassle of adjusting the ventilator settings as well, and an optimized drug administration or the smart pilot. We'll talk about these in detail. So, when we talk of automatic control of anesthesia, nowadays, how do we provide anesthesia? We see the clinical features, hemodynamics, heart rate, or if we are blessed to have process EEG, we see the process EEG, and based on that, we adjust the dial setting on the vaporizer manually. So that is how anesthesia administers. We adjust the fresh gas flow. We are constantly adjusting the concentrations of oxygen, nitrous oxide, or air to achieve desired FiO2. And then we set the fresh gas flow if the patient becomes lighter, or if we have to suddenly increase the depth of the anesthesia. We either increase the vaporizer setting, we increase the dial setting, or we increase the fresh gas flow. So everything is being done manually based on the input received from the patient. That is a semi-closed system. That is how it is being done. Now, when we talk of automatic control of inhalational anesthesia, it's very simple. All these three machines work on more or less the same principles. They might have different algorithms, but more or less they work on a similar system. So, TCA, total control of anesthesia, automatic gas control. TCA is Traeger, automatic gas control is Gettinge, iFlow, and ACA is your automatically control anesthesia on Mindray A9. So all these three work more or less on a similar system. Now, it is very important that you enter the patient parameters the moment you switch on the machine for that particular patient. That you have to enter his age, the sex, and height of the patient. From this, what the machine calculates is the weight of the patient, the ideal body weight or the predicted body weight of the patient, and the BMI of the patient. Also, age is required to adjust the MAC. There is something called as age adjusted MAC. Now, all the MAC values that we read in the textbook are for an age of 40. Now, there's a formula which we all know that infants require more MAC, and as the age increases, gradually the requirement of MAC decreases. So the MAC value decreases. So based on the age, it will calculate that what is the age appropriate MAC on a particular dial setting. So that is why these inputs are important whenever you're doing a control loop anesthesia system. The anesthetic inputs include the FiO2. What is the FiO2 that the machine has to deliver to the patient? The choice of the gases, obviously, whether you want to use oxygen with nitrous oxide or oxygen with air, that is your choice. That has to be entered, obviously, to achieve a particular FiO2. Then the end tidal anesthetic concentration. So we all know that MAC is nothing but the end tidal anesthetic agent concentration, end tidal anesthetic concentration that is used to calculate the MAC for a particular age. Now, in this, we do not directly put in a MAC. Now, what we do is we set an end tidal anesthetic agent concentration to be achieved, and on a side window it will show you what will be the MAC achieved for that particular and end tidal concentration of the anesthetic agent, like for ETCBO or 40-year-old male patient, right? Let's check up that. So to achieve a MAC of 1 for a 40-year-old patient, I'll have to set the dial setting to 2. So that is what I'll do. I'll set the end tidal anesthetic agent to be achieved. I don't set at what percentage the vaporizer has to open. Everything will be calculated by the machine. Then the speed of induction. The machine will show that at how much time will it take to achieve that particular end tidal anesthetic concentration for a particular flow. Now, this can be set manually or this can be left on the machine. You can just set the time that I want this much of concentration, end tidal anesthetic concentration, to be achieved in this much of time. So that way you can also set in how much time, at what level, at what flows the induction should occur, at what concentration of the vaporizer the MAC would be achieved. You set a time, that this is the time I want for the patient to achieve this particular end tidal anesthetic concentration or MAC, right? So it will automatically decide the speed of induction as you set the speed of induction, and it automatically decide whatever fresh gas flows are to be given, and whatever how much the vaporizer is to be injected. Now, one thing is important, that with these systems, what we don't use is the conventional vaporizers, the flow over vaporizers. What we use is a injection vaporizer. That means that the liquid is injected directly into the gas. A pre-calculated amount is injected directly into the gas, which turns into the vapor, and a faster target concentration can be achieved. So, as I said, the gas flows vaporizer setting is decided by the machine in this particular case. So, it's very simple. Uh, in the wind, smart ventilation control and automatic controlled anesthesia, that is in the trigger and the Mindray, you can to a certain extent automate the ventilation as well. You can say whether the patient is to be ventilated manually, or a controlled breathing is to be done, or whenever the switchover should occur. That also you can set, so the ventilator will sense and accordingly help you wean off the patient as well. So you have some control over the ventilatory settings as well, which can be control in the sense you give the mandate to the machine to control the ventilatory settings as well, to set in the minute ventilation, whether to increase or decrease the minute ventilation accordingly based on the input from the patient. Also, in all these three machines, we have something called as lung recruitment tool. Now, we all know that anesthesia causes basal atelectasis, and this can cause significant problems in the postoperative period. Excuse me. Significant problems in the postoperative period. So, the lung recruitment tool can be as a single step maneuver where we set a pressure and a particular time, and it compares the compliance before and after the maneuver. Like, say you set a recruitment maneuver of say 30 centimeters of water for 20 seconds. So it will give you what was the compliance prior to that and after that, and you can see if the compliance is improved or not. Or what you can do is you can use a multi-step maneuver, in which it can be either incremental in steps of 2 centimeters of water, or a decremental recruitment, in which you start from the higher pressures and you come down gradually, and you see at what peak or at what pressures the compliance is the highest, and accordingly you can also use the cursor to determine the optimum peak during the decremental phase. Now, what happens is, in the incremental phase, you set an upper limit, say 40 centimeters of water or 45 centimeters of water. That is the maximum that you'll go, or 30 centimeters of water to be on the safer side. Now, as the pressure is increasing, we all know that as the pressure increases, there is some hemodynamic compromise. Now, if the hemodynamic compromise occurs, it is in the hands of the clinician, that the clinician can stop the further increase and start the decremental phase, and the peak will start decreasing. So again, it helps you arrive at the what do you call it, the optimal peak. So you can optimize the peak which is there. As you can see, there's a slight step-like structure in this graph, and you can see the compliance being shown here. What is the peak inspirator pressure, what is the PEEP, and accordingly you can see what would be the optimal PEEP for that particular patient. So this is helpful in patients with pulmonary disease. Now, as I said, there is something called as smart ventilation control dragger, in which the initial mode is set by the anesthesiologist, and there is an automated transition from control to spontaneous stress. So we set the spontaneous ventilation control, we set the pressure and the frequency, then there's the patient. On the basis of EtCO2 and tidal volume, it will increase the tidal volume or the pressure or the frequency to achieve a particular CO2 level, and switch over from control to spontaneous breath when the patient has started breathing, and come down gradually on the assisted breath or the assistance, depending on the patient effort. Let us see here. If you see here is the range where the mechanical ventilation, we have said that the tidal volume, rate and pressure and everything is to be started to maintain you can see this green band here, the EtCO2 should be in this range. Now, from here, we say now that the patient has to start breathing on his or her own. We have reversed the neuromuscular blockade. So, if you see here, the green band shifts slightly higher up so that the respiration can be triggered. And as the patient effort increases, the assisted breath support decreases, right? So the SVC reduces the mechanical ventilation contribution to maximize spontaneous breathing if the patient is ready to breathe spontaneously. So it helps in weaning also, and we have a ventilation control as well in this particular system. Smart Pilot. Now, Smart Pilot is a trademark for Dragger, but then the ACA or the Mindray also gives you something like a Smart Pilot. It is nothing but a simulation of effects of hypnotics and analgesics. It displays the depth of anesthesia as a projection. And if we say that we are going to increase the MAC from 1 to 1.5, so what will happen to the base? What will happen to the BP? Or if you increase the effect site concentration of propofol from 3 to 4, what will be the projected base over the next 20 minutes? And in the reverse chronology also, that means that if we stop the propofol now, or if we stop the inhalation now, what is the time that the patient will take to wake up? So this can help in maintenance phase also, and it can help in the reversal phase also. That means you very well know that the surgeon says, I'm about to be done in 5 minutes. Okay, fine. So you you start reducing it. When you're using a conventional machine, you're not sure when the patient is going to wake up. How much time is he going to take up to wake up from when you switch it off? Here, the machine will tell you precisely when the patient is going to wake up once you switch off your anesthetic gases or the anesthetic agent. So it has this thing graph for both the inhalational, the propofol, and even analgesic to a certain extent. So it will prevent overdosages. That means, okay, now I feel okay, now the surgeon is going to take time. Let me increase it, or let me give a propofol to the patient. The surgical stimulus is going to be there. So you give it, and suddenly you find out now the surgeon is almost done. So when you give this particular drug or you increase the drug, it will give a prediction over the next 20 minutes how the patient is going to behave, what will be the depth of anesthesia. So it will help in smooth maintenance of anesthesia, smooth end of anesthesia, which will result in a better recovery of the patient. So that is the Smart Pilot or the smart dosing feature that you have in Draeger and in Mindray. Okay, now this was about inhalational anesthesia. Now let's come to TIVA-TCI. Closed loop anesthesia delivery system was initially described with TIVA-TCI because we are already using an algorithm to deliver propofol, remifentanil, and other drugs. Now in this, we have an anesthetic depth monitor. This can be clubbed to a vital sign monitor, a TOF, and then this feedback is given to the algorithm on the basis of which it will regulate the propofol. If we have a noxious monitor and on the basis of a vital sign monitor, the opioid, or on the basis of TOF, the muscle relaxant bolus if required. So that is all can be done by the computer itself. All we have to do is set up the limits, set up the ranges, set up the infusion pumps, refill them when they're empty, and sit back and relax. Everything will be controlled by the computer. So as you can see, how does the physical sign monitor work? In case there's a hypertension, tachycardia, movement, or autonomic response, that means first thing is that it will say that the patient is light. If the base value is high, then it will assess the surgical stress, increase the hypnotic or the analgesic. If the base in the desired range, then that means that it is noxious stimulus. It will increase the antihypertensive administration. We have to give more analgesics. And if the base value is low, but the patient is showing an autonomic response, That means that we have to see whatever is the problem and act accordingly. Similarly, we can have this flowchart incorporated into the algorithm, and the infusion of the doses of the hypnotic, analgesic, and muscle relaxants can be controlled by the computer itself based on the algorithm. So if you can see here, we have propofol, remifentanil, rocuronium, dobutamine, sodium nitroprusside, all in this. Based on the pain index, the EMG signal, ECG signal, EEG signal, and the vital monitor, it goes to the computer and it adjusts the drugs to achieve a desired response. But remember, even when the plane is flying on autopilot, the pilot is not sleeping. The pilot is monitoring the controls, the pilot is monitoring the flight path. So the role of the anesthesiologist is important. All this cannot replace the anesthesiologist. In fact, the role of the anesthesiologist becomes much more important, because when we are doing things manually, we know what we are doing. But here, an error on the part of the machine can be disastrous. So you have to be much more vigilant when you are using closed loop delivery anesthesia systems, because you have to monitor something which is not being done by your hand. So that is very important. So this cartoon I had shown earlier also. That is how it works. So as I said, for TIVA TCI, first it does is it checks the validity of base using a signal quality index, if it is valid. If the base is outside the target range, plus minus 5, it will see the previous trends and set the rates accordingly, or not. If the range is outside, it will start a new propofol rate, wait for the effect of the drug delivery. It will again collect base, again check the validity, again see whether the base has come back to normal or not. Now this is one parameter for base. You can just replace base with other monitors, and other drugs can be controlled. Okay, so this is how a closed loop delivery anesthesia system for TIVA TCI works. So what are the advantages? Now we have been talking about the advantages all the time. Maintains optimal anesthetic depth because there's a constant feedback. The effect of boluses and everything is reduced. Reduces human error. There's a real-time feedback for anesthesia providers. It can even help in early detection of complications. As I said, with the Smart Pilot, it can show you whether there's going to be hemodynamic hit or not. Thereby, with all these things, it enhances patient safety and outcomes. You can individualize the drugs and dosages to each patient. Obviously, because if you are using inhalation agents, if you are using TCI, it will be individualized. So the agents, whether it's inhalation or propofol or the analgesic, the requirement is much less. If you are using TIVA TCI, even if you are using inhalation agents with the reduced flows, there are environmental benefits. And the most important of all, today is the day and age of big data. So all these data is being collected centrally in the computer, which you can use for further analysis, research, and development of new algorithms and programs for further betterment of the system. Disadvantages, obviously, the other side of the coin. It is very high, costly. The technicalities are complex. We have to have a system validation and safety. Only a very few systems are valid. Again, the sensors are important. Suppose your ATCO2 is not properly calibrated, or if your SpO2 is not working, you can have an SpO2 in the loop to decide the FiO2 or not. Hypoxic guard. So if the saturation falls, it will automatically turn up to 100%. Or if the FiO2 decreases to a particular, if the FiO2 decreases, then which can happen with low flows in closed circuits, the hypoxia guard will be activated. Then it might take some time, because there's always a delay between the what the patient is experiencing. The signal will be, the sensor will get the signal, it will send it to the computer, it will be assessed. So there might be some delay, and that will lead to adaptation to dynamic patient states a bit difficult. The operators, the anesthesiologist at the helm, has to know what he's dealing with, how the system is to be used. Again, you cannot just leave it on autopilot and go and have a cup of coffee. And again, when we say that it enhances personalization, but then we are still in infancy, the algorithms may not be suitable for all populations. So we might have to have different algorithms for different set of patients for different disease conditions, which will lead to further personalization of anesthesia and drug delivery systems. Future directions, we can expand it to other clinical areas: ICU, pain management, non-operating room anesthesia. Then data analytics and predictive analytics. As I said, we have the data now. We can go in for better predictive models. Uh, we can integrate AI to further personalize the dosing based on the patient condition, the BMI, obese, thin, lean, elderly, children, neonate, whatever. We have all sorts of permutation and combinations. Uh, Closed loop inhalation control expansion, we can expand it to use right now when we are using inhalation anesthesia, it is only for the inhalation agents. We can expand it to analgesics, we can expand it to um, muscle relaxants also. It can help in remote monitoring and mentoring. In fact, it can help in remote anesthesia as well. And we can one day hopefully have a fully autonomous anesthesia system, just like the robot, where the anesthesia after intubation, anesthesiologist might be sitting outside on the console and controlling everything from a distance. So that is what the future holds for us, maybe. And is it possible? Well, the mind thinks, or the mind can fly to what it can achieve. So, yes, quite possible. We might be having a cup of coffee over a console and away from the operating room per se. So, in all, if you see, we have the mechanical robots now. We have robots for regional anesthesia, tele anesthesia. Now, all this big data that we are collecting can help in clinical decision support systems. As I said, prediction of complications, and everything can be done. And obviously, we have this closed loop anesthesia delivery system at the starting, which will make all this possible in the near future. So it might seem difficult, but everything is difficult unless you practice. And once you practice, nothing is difficult. The anesthesia is expanding, ever expanding. New vistas, new opportunities, new technologies are emerging, and we need to change with the times, because once upon a time, this was also anesthesia. Thank you so much. I'm open to questions. Over to you, Faraz.
Thank you so much, sir, for taking out your important time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice too. Sir, we have received some questions from the participant. With all your
Sure.
permission, shall we take this one by one?
Sure.
First question is, sir, how do closed loop system adjust to interpatient viability in aesthetic requirements, sir?
So as I said, intervariable, this is something that you still need the anesthesiologist. Now, one thing that we can do is if we enter the patient characteristics correctly, like the age, sex, and height of the patient, yes, but then all 50 kg patients, predicted body weight 50 patients may not behave the same. A 40-year-old male with predicted body weight of 50 kg may not behave the same as any other patients with the same figures. So that is where the anesthesiologist has to be at the helm, and we still have a long way to go uh, till we reach that completely autonomous anesthesia delivery system. So that is what we are here for, to tailor and to adjust and to modify.
Thank you so much, sir, for sharing your insight on that question, sir. Moving forward, we have another question, sir. We will take second question. What are the current limitation of BIS guided closed loop anesthetic in complex surgical cases, sir?
Okay, so I would say that CLAD has been used for cardiac surgeries as well, and it has been shown to be better than manual control of anesthesia. BIS has its own pitfalls. Yes, definitely. When we are using nitrous oxide, we are using certain agents. There are certain surgeries where BIS may not be possible. There might be signal errors. So all these fallacies do occur, but wherever possible, even in complex surgeries, control loop is has been shown to be much better than the conventional way of doing things. So we cannot control it that precisely. Yes, there are going to be errors, but then we are there to oversee that errors that the machine makes. And overall anesthetic consumption, hemodynamic variations, errors that occur, the recovery profile is definitely better with closed loop system as compared to the conventional anesthesia delivery systems.
Thank you so much, sir, once again for sharing your expertise on that question, sir. One last question we will take, sir. Like
Yeah.
with this, that is based on AI, sir. Can AI-based closed loop system outperform experienced anesthesiologists in maintaining hemodynamic stability, sir? What's your point of view on that?
Okay. So AI, yes. I wouldn't say yes, it can perform the human mind, because ultimately it is the humans who have designed AI. Now, this is a matter of great debate, and you're also talking of robots taking over the earth and the human mind. It is up to us whether we want to maintain our intelligence, questions, and our superiority over the machines. There was a time when we had those dial phones. I have seen that era, and we had a memory of all the phone numbers at home and the neighbors. But now with the advent of smartphones and mobile phones, I don't even remember my home landline. I have to If I have to dial the number, I have to look to my phone. So it is up to us how much dependent we become on AI. And yes, if we allow ourselves to degenerate and lose our capabilities, then definitely AI can outperform us. But as long as we try and be one step above, we don't we practice what we are doing, we do not leave everything on the machines, then I don't think so that AI can perform better. There'll always be, it's like the lion, sorry, the cat teaches lion everything except climbing on the tree. So that is its escape mechanism. So it is entirely up to us how dependent we want to get on AI. Thank you.
Yes, sir. Thank you so much, sir, sharing your expertise on that question too, sir. Very well explained, sir. Sir, as I can see, no further questions are there, sir. With all your permission, shall we conclude this session for today?
Yeah, please. Thank you.
Okay, sir. And we would like to see you in future also with different topics, sir. It was great honor to host you, sir. Until then, take care of yourself, sir. Thank you so much for
Thank you.
joining.
Thank you. Thank you, Farah. Thank you so much.
Welcome, sir.